So guys, how will a patient with peptic ulcers present? So the clinical presentation for a patient who has got peptic ulcer disease. Clinically, you can't really differentiate gastric ulcers from duodenal ulcers. So the presentation is very similar when it comes to those two. And also we should understand that the clinical presentation will depend on, is the patient presenting with uncomplicated or complicated ulcer. So these patients, as much as they both have peptic ulcer or peptic ulcers, they will present differently. Let's talk about the one who's got uncomplicated peptic ulcer. So there's no complication here. So it's gonna be that patient who comes in with a history of dyspepsia, which is just an epigastric pain. It can be a pain, it can be just a discomfort. It can be just a burning pain. It can be a burning pain that is in the epigastric region. And also they can also present with vomiting. They can also present with nausea plus or minus vomiting. So, and one of the, but I don't want us to get into those, but one of the differences between duodenal and gastric ulcers in terms of history. Apparently, the patients who have got gastric ulcers, but it's not very specific, guys. This patients who got gastric ulcers, when they eat, they trigger the ulcer. So eating worsens or triggers the pain, as opposed to duodenal. Eating comforts the pain or reduces the pain. And then they would even say that these patients, they end up gaining weight. These ones, they end up losing weight because of that. But majority of peptic ulcers, they get this pain in the early hours of the morning. Especially those after digestion has taken place. I assume that for duodenal ulcers. But these are not really specific, guys. They are really not specific. Even epigastric pain is not specific for ulcers, as we all know. So remember, the approach for someone who's got uncomplicated ulcers will always be your history, physical examination, and then from your history, if they present with what you think it's epigastric pain, then you'll start asking them about NSAID use, stress ulcers, psychological stress, all those things that you can think of that can be causing them, that can cause them from having ulcers. That would be someone who's got uncomplicated ulcers. So so they will also have loss of appetite and all of that. What I've realized is, but I'm not sure which type of an ulcer it is, because obviously it's just clinical. When an ulcer is like so painful, when it's like the patient's got an acute attack, they just vomit everything, even water. They just vomit, like pure water. They even vomit that. So yeah, so let's just let's talk about how you let me do management on another video. Okay, complicated ulcers. A patient who presents with like we said, the complications of ulcers: hemorrhage, a perforated peptic ulcer, hemorrhagic ulcer, gastric outlet obstruction, they also talk about fistulization, so those are the complications that you expect. For someone who's got so like I explained in another video, that when you have a peptic ulcer like this, so if we zoom into this, then we start seeing the structure, we start seeing this, all those layers: the mucosa, the submucosa, the muscularis, the serosa. And we said that a peptic ulcer by definition is a defect that goes all the way up to the muscularis. So if this ulcer erodes any further than the muscularis, it gets to the serosa, and then that's when perforation can occur. So that would be perforation. Now, which means that when you've got perforation, depending the location of the perforation, but then the gastric juice, the acid, all those things, the pepsin, will have a chance to escape into the abdomen. This patient will be peritonitic, because now you're going to have gastric contents that are just all over the abdomen. This patient will be very sick, will be peritonitic. They will be in so much pain. So yeah, so the pain that these ones will have will be much more severe than someone who's got an uncomplicated. And another difference with that, their pain will be generalized, going to be a generalized abdominal pain, because of that gastric fluid that is filling the abdomen now, that is just outside the stomach into the abdomen. So they will have generalized abdominal pain. They shouldn't really come in. They should not come in shock. Because they are not bleeding. Those ones, they should not come in shock. They should come in pain. They should not have melena. They should not have they should not even cough. They should not have hematemesis, coffee ground vomiters. They should not even have those. So mainly there is just generalized abdominal pain. Now, if it happens that you have an ulcer like this, and then you've got an artery that is running somewhere there, if this perforation ends up getting to the artery, then that's when now they're gonna have a hemorrhagic peptic ulcer. And the way they will present with they'll present in pain as well, generalized abdominal pain, because now they're going to have a generalized abdominal pain. They will have they might even come into shock. They might come in unstable, needing resus first before you can take history and do any other thing. They might come in shock, hemorrhagic shock, because they are bleeding. So they will come in with coffee ground, and these patients can bleed. They'll come in with they might come in with melena, stools, in shock, in so much pain. They might even come in with pallor. They might be pale because they have been losing blood, and yeah. So please, guys, watch a video where I've discussed upper GI bleeding. I speak about that in upper GI. How do you? Because this will come in with upper GIT bleeding, basically. Someone who's got gastric obstruction is going to be that patient who comes in with vomiting. They've got early satiety, because if you have got and I explained why would they get gastric obstruction, and this is specifically for duodenal ulcer. So with there at the duodenum, if you have an ulcer somewhere here or somewhere here, when that ulcer heals, it heals with fibrosis, and the more you keep getting acute attacks, it heals with fibrosis the more, to a point whereby this when food comes in now, sort of like gets stuck here, because when food comes in, this is supposed to dilate a bit to allow the food to go out, but when you've got fibrosis, it's not flexible anymore, so that food that comes here gets stuck and cannot pass. So this patient is gonna have early satiety, meaning they would eat small amounts of food and already they are full. They will have nausea, vomiting. They might even come in with a mess in the epigastric region as well. They might even come in with a mess there. So and they might also come in with electrolyte imbalances too, but you can only pick that up on when you do your ABG. So fistulization is not very different from a perforation. So you get a perforation here, but instead of a perforation, so you get a perforation, but then there's communication with another organ, and then so it's a communication between two epithelial surfaces. So there's a fistula that has developed there. It's not, I've never seen it. One thing that I've seen is I've seen this one more than this one. So these are the most common ones. So these are communications worth reading about, guys, because they will ask you about these things. One other thing that you must also understand is that someone who comes in with epigastric pain, that pain should not radiate. If it's radiating, especially if it's radiating to the back, then it could be that they've perforated, if it's radiating to the back. And also this pain should not be felt on the right hypochondriac region as well, because if this pain, as you examine, you feel the tenderness here, this is the epigastric region, right? This is your left hypochondriac, this is your right hypochondriac, this is your epigastric. So if when you examine them you feel that there is tenderness here and also there is tenderness around here, then it's likely that the main problem is in the biliary tree here. I have seen a patient who was treated by some doctor. So this patient went and presented with epigastric pain and was given PPIs, which is the medication to treat the peptic ulcers. A week later, the patient came back. No, not even a week later, but 3 or 4 days later, the patient came back, and I saw the patient. When I saw the patient, I realized that the patient has got epigastric pain plus right hypochondriac tenderness as well. So basically, this patient did not have peptic ulcers per se, but when we took her for an ultrasound, she had cholecystitis actually. She had cholecystitis. So the thing is this here is that it's easy to miss biliary tree pathologists just because they present with the epigastric pain. So whenever a patient comes with epigastric pain, make sure that you examine the whole abdomen and especially the right hypochondriac, because biliary tree disorders can still give you epigastric pain as well. Very, very important, guys. Okay, we'll do another video and do the management now.